Hello, my name is Rizvi, and I'm an assistant professor at Morgan Stanley Children's Hospital, Columbia University, New York. Thank you so much for joining me today to learn about pediatric point-of-care knee ultrasound. By the end of this presentation, you will be familiar with the indications of knee ultrasound. We will learn what probe to use, the normal sonoanatomy of the knee joint, and common pathologies seen in an emergency setting. We will also go over the pearls and pitfalls of knee ultrasound. Ultimately, we will review an illustrative case to apply what we've learned today. Knee ultrasound is extremely useful while evaluating for knee pain and swelling. The knee is the most commonly injured joint by adolescent athletes, with an estimated 2.5 million sports-related injuries presenting to the EDs annually. It is also one of the commonly affected joints in septic arthritis. Ultrasound may detect effusions as small as 7 ml in the knee joint space, and in one study had a sensitivity of 91.6% in detecting effusions when compared to MRI. For this application, a high-frequency linear transducer with a frequency of 5 to 10 megahertz is used, given the superficial location of the structures. Setting or preset will be musculoskeletal or small parts. Depth should be adjusted to visualize the bony cortex of the femur and patella in the suprapatellar region and tibial tuberosity in the infrapatellar region. The patient should be positioned supine with knee slightly flexed to 30 degrees. This can be easily obtained by placing a towel roll under the patient's knee. For a comprehensive evaluation, the structure of interest should be scanned in both longitudinal axis and transverse axis planes. The asymptomatic side can be used for anatomical correlation and comparison. Minimal pressure should be applied to avoid masking of small effusions, as knee effusions are compressible. This can be achieved by applying large amount of ultrasound gel, which also ensures patient comfort. Finally, color Doppler can be applied to show lack of signal. For longitudinal view of the knee joint, the transducer is placed longitudinally over the quadriceps muscle and tendon, in the midline superior to the patella. The indicator of the probe should be pointed towards patient's head. In this view, the bony cortex of the femur and the patella can be seen as hyperechoic linear structures. The quadriceps tendon appears slightly hypoechoic deep to the subcutaneous tissue, with its longitudinal fibers attaching to the patella distally. The anterior suprapatellar recess is identified deep to the quadriceps tendon, between the suprapatellar and the prefemoral fat pads. The transducer is fanned from medial to lateral to visualize for any fluid collection. For transverse view, turn the probe 90 degrees with probe marker now facing the right of the patient. The prominent anatomical landmarks in this view are the quadriceps tendon, which can be traced down all the way to its insertion on patella and femoral cartilage. Be careful not to confuse the femoral cartilage with an effusion, which is generally seen above the fat pad. Fan superiorly and inferiorly for a comprehensive evaluation. A knee fusion is defined as greater than 2 millimeters of hypoechoic fluid deep to the quadriceps tendon in the suprapatellar bursa that has direct communication with the knee joint. Any fusion should also be interrogated in transverse axis to demonstrate similar findings. Effusions can be homogeneous or heterogeneous. Homogeneous effusions are typically seen in transient synovitis or acute hemarthrosis. They are uniform, anechoic, or hypoechoic. Heterogeneous effusions contain echogenic particles or fronds in anechoic fluid, which may represent escaped blood and fat from bone marrow in the joint due to trauma, called lipohemarthrosis, or they could be infectious or inflammatory particles. Effusions show displacement of fluid when compressed and do not exhibit signal on color Doppler. This is in contrast to synovial hypertrophy or synovitis, which is defined as an abnormal hypoechoic intra-articular tissue that is non-displaceable, poorly compressible, and may exhibit Doppler signal. Effusions can be very subtle in some cases, which emphasizes the practice of always comparing the affected limb with contralateral asymptomatic side. Ultrasound can be used to do assist or guided aspirations of large effusions in the emergency department for diagnostic workup. The suprapatellar recess can be accessed by placing the transducer along the transverse plane and the needle entering from the lateral side of the quadriceps tendon. Finally, both the quadriceps and the patellar tendon can be evaluated for injuries. To visualize the infrapatellar tendon, place the probe longitudinally with probe marker towards the head of the patient. The infrapatellar tendon can be seen as a hypoechoic structure with fibers running from the inferior pole of the patella to the tibial tuberosity. Deep to the tendon lies infrapatellar fat pad, also called the Hoffa fat pad. This is an example of a quadriceps tendon rupture, which appears as a discrete hypoechoic focus visible within the tendon, representing the intratendinous hematoma or edema. While this is an example of a complete patellar tendon rupture, which appears as a full thickness discontinuity of the tendon. One of the pitfalls to be wary of is anisotropy. Anisotropy is the property of tendons, nerves, and muscles to vary in their ultrasound appearance depending on the angle of inclination of the incident ultrasound beam. Simply put, because of anisotropy, a normal tendon can appear to have a partial rupture or a tear, such as here. This variation can be counteracted somewhat by ensuring that the transducer remains directly perpendicular to the tendon in both the transverse and the longitudinal planes. And now to our illustrative case. A 3-year-old female presented to our emergency department with a 3-day history of left knee swelling and abnormal gait after minor trauma that occurred several days prior to presenting. Parents had tried analgesics without any relief. Her vitals were normal. Her physical exam revealed a playful toddler with suprapatellar soft tissue swelling without erythema, fluctuance, warmth, or tenderness to palpation. She was ambulating in the ED without any limp. Bilateral radiographs of the knee did not demonstrate any effusion or fractures. A point-of-care ultrasound obtained demonstrated bilateral knee suprapatellar effusions containing complex heterogeneous material, mostly concerning for hemarthrosis with clotted blood versus an inflammatory process. Extensive workup was performed, including inflammatory markers and a knee MRI, and patient was given presumed diagnosis of oligoarticular subtype of juvenile idiopathic arthritis, which was confirmed after 6 weeks of persistent symptoms. She was initially treated with NSAIDs and later treated with intra-articular corticosteroids due to severity of her disease and worsening of symptoms. So in summary, ultrasound of the knee is a highly sensitive test that can be easily performed at bedside. While imaging, always remember to image in 2 planes and compare the asymptomatic side for anatomical correlation. Ultrasound guidance can make arthrocentesis safer by direct visualization of the needle. And always remember the common pitfalls while evaluating for effusions and tendon rupture. Thank you so much for your time and attention, and these are my references.